Hello. Hi, everybody. Welcome. I'm very pleased today to welcome Dr. Denis Dillard. Dr. Dillard, I'm going to just read this if you don't mind. Dr. Dillard is of Inupiaq Eskimo descent, born in Fairbanks, Alaska, and raised in Anchorage. She actually graduated from Colorado State University with a doctoral degree in counseling psychology, and during her program, she completed her pre-doctoral internship here at the University of Colorado, well, here is in the 9th Street campus, Health Sciences Center at what was the National Center for American Indian and Alaska Native Mental Health Research, working with Dr. Candace Fleming. After graduation, she continued to work at the center with Spiro Manson for 3 years before returning to her native Alaska. She's a licensed psychologist and director of research for the Southcentral Foundation, a nonprofit tribal healthcare organization serving over 65,000 Alaska Native American Indian people. The Southcentral Foundation achieved the highest level of patient-centered medical recognition from the National Committee on Quality Assurance in 2010, and in 2011 was awarded a Malcolm Baldrige National Quality Award in the healthcare category. Dr. Dillard has worked for SCF since 2001 and spent more than 18 years conducting quantitative and qualitative research. She oversees the direction of a variety of research projects in behavioral health, cancer, pharmacogenetics, health disparities, patient-centered outcomes, and other areas. Clearly very busy. She's essential in coordinating the Foundation's research efforts and bridging communication with academic institutions and other research partners, as well as developing relationships with the NIH, CDC, and other funding agencies, as well as academic institutions. She works directly with the SCF Board of Directors as they review and consider approval of research involving Alaska Native people in and around Anchorage, and serves on the Alaska Area Institutional Review Board. Please welcome Dr. Dillard.
Okay, so let me test this. Can you all hear me?
Yeah.
Okay, well, it's very nice to be back in Colorado. I've been back in Alaska for, I think it's 16 years now. So, but Colorado definitely has a very fond place in my heart, particularly the nice weather, although right now not so nice. But I want to thank University of Colorado for inviting me. I am going to be talking about some of the care and research that is done at Southcentral Foundation, which is based in Anchorage. But before I do that, kind of a little bit more about myself. My mother is Inupiaq Eskimo from King Island, Alaska. It's a small island off the coast of Nome. Nobody actually lives there anymore. Part of the history of Alaska is that much of the Western schooling was provided by missionaries who came into the state of Alaska, and on the island that she was living on, the church stopped sending missionaries out to do schooling. My mom had already left the island by that point. When she was in 8th grade to go to boarding school, which was pretty standard at that time. And so nobody lives on the island anymore. So my family, that side of my family, relocated to Anchorage because my grandfather had really bad arthritis, and so they wanted to health care. My father is not Alaska Native. He's German and Irish. He met my mother at University of Alaska Fairbanks. He's an electrical engineer. And I was born shortly after they got married. I also, before I move on, I want to make really clear that everything I'm presenting today, this is not all me. I have many wonderful partners. So there's all the people back at Southcentral Foundation, including customer owners. We call our patients customer owners, and I'll kind of tell you why in a bit. Research participants, the different divisions of Southcentral Foundation, so medical and behavioral services. We also have a Family Wellness Warriors initiative that is looking at the effects of different types of trauma on health, and they actually do a peer-led intervention kind of across the state of Alaska. And then there's the many partners of mine within the SCF Research Department. I work with about 10 people total, so this is about half of them are scientific. I also, some of this research was done while I was a Native investigator through the Native Elder Research Center. There's lots of acronyms around here, which is now the Center for American Indian and Alaska Native Health within there. Spiro Manson was my primary mentor, and then different folks at University of Washington. I continue to partner with University of Colorado Denver, and some of the projects I'm working on work with Douglas Novins, and as well as Lori Moore. University of Alaska Anchorage has been another one of our partners, and then also Cherokee Nation Health Services. So I am going to present quite a bit of information about Southcentral Foundation because I think it's really important to understand the context within which the research that I've conducted occurs within. It's a pretty unique system, and so I think that's really critical to understand. I'm also going to provide research results. I have a pretty diverse portfolio. I have way too many slides, so we'll see kind of how far we get. But what I was going to kind of prioritize was research about behavioral health integration into primary care, so that's kind of the primary focus that I'm going to have. And then I'd love to have an opportunity for questions and comments. So I will try to keep close track of the time. So a little bit of background. I don't know, are many folks here in the room familiar with the with services provided in Alaska? So the Alaska Tribal Health System is a affiliated group of over 30 Alaskan tribes and tribal health organizations that provide health services to Alaska Native and American Indian people. So through Public Law 398, more and more tribes across the nation over the past couple of decades have taken over provision of their own health care. And Southcentral Foundation, and actually many of the tribes in Alaska have taken over provision of their health care, which was traditionally provided by the Indian Health Service, which is a federal organization. Each tribe or tribal health organization serves a specific area, and the total population is roughly 130,000 Alaska Native and American Indian people. And the tribal health organizations, for the most part, are really responsible for providing the spectrum of care. There is some specialty care that might be provided in Seattle, like for cancer, but really most of the services are provided within Alaska, although people often fly into Anchorage. So this is a map of the Alaska Native Health System. There is a total of 229 federally recognized tribes and villages, and so there's tremendous diversity. And each of the kind of the shaded areas, they are loosely associated with different cultural groups, although there's some overlap. So in the upper part, the light yellow and the pink is Inupiaq. The middle is Athabascan. We have Yupik Eskimo, which is some of the light green without the shaded. We have the Alutiiq people who are on the Aleutian chain, the big part going out into the ocean. Southcentral Foundation, you'll see, is kind of located in the gray shaded area, and Anchorage is the most densely populated part of Alaska, so we have about 400,000 people, but that's pretty much half the state. So you can imagine the population density in the other areas. There's an average of one person or less per square mile in Alaska. So a lot of care is really provided in pretty rural locations, and a lot of Alaska, for those of you who don't know, is not accessible by roads. You have to fly to go most places. So there's a lot of traffic that comes in and out of Anchorage, where Southcentral Foundation is located. And then you have Southeast Alaska, and so you'll see the tremendous diversity. You'll see that there's mentions of corporations. So one of the ways that Alaska is different than other indigenous groups in the United States is there's actually only one reservation in Alaska, and it's in Southeast Alaska, and that's the Metlakatla Indian community. The way things are structured there is it has to do with the Alaska Native Claims Settlement Act. So the Alaska Native Claims Settlement Act divided the state into these different regions. Each region has a corporation, and then health is provided by a nonprofit health arm of these different corporations. The corporations themselves are for profit, although there's tremendous variability in how successful the corporations have been in gaining profit over the years. So a little bit of history about Southcentral Foundation, so that's primarily what I'm going to be focusing on now. So 1982 is when Cook Inlet Regional Incorporation incorporated, which is one of the Alaska Native Claims Settlement Act corporations, established Southcentral Foundation. In 1985, SCF assumed management of dental, optometry, and community health, and it was this little tiny building there in Anchorage. And actually the current president, CEO, started off as an administrative assistant there in our Fireweed location. In 1998 is when SCF took the big step of assuming management of the region's entire primary care system. So it's not only based in Anchorage, but Siri villages, which I'm trying to remember how many different villages that we have. I always have to look at my notes. I believe it's 61 villages, so it's a very large area. And then in 1999, they assumed co-ownership and co-management of the Alaska Native Medical Center. So Southcentral Foundation is an outpatient provider of services. So anything outpatient, Southcentral Foundation is responsible for providing. The Alaska Native Medical Center is our hospital, and that is co-run with another statewide entity, because many of the specialty inpatient services are needed by the entire state, so it's kind of managed by a consortium of tribes. So in 2000, some of the research I'm going to be presenting, around in 2000, 1990, 2000 is when SCF really started to make very dramatic changes in how they approached healthcare and how they provided healthcare. And in 2000, they introduced what is now called the NUCA system of care. NUCA is just a word for something that's big, kind of beyond everything else. We refer to it as a system of care because all the parts are interrelated, and the goal really is to have all the parts work together versus many of other medical settings where you kind of have these little silos. SCF has been very deliberate in not trying to recreate that, and so we refer to it as a system of care. So since 2000, there has been same-day access to primary care services, and I'm a customer owner. I receive my care there. And then this really only presents a couple of new things, but they have opened several new facilities. They keep growing and expanding. The research department is actually getting ready to move into a new building mid-April. And then in 2011, SCF was honored to win the Baldridge Award. We currently have 65,000 people that we serve, although that's a constantly moving target. There's a lot of people who move into Anchorage from rural villages, and then they may go back. But over time, there's more and more people coming into Anchorage as the economy gets harder in rural Alaska, where things are tremendously expensive, and there may not be the same number of job opportunities or educational opportunities. We might have, I think, 1,900 employees now and over 65 programs. And the programs run from primary care. We also have women's health, pediatrics. We have a laboratory. We also have a very large behavioral services division that has both inpatient and outpatient substance abuse services. And we also have like an elders program. So we have a bunch of different programs. So how did SCF approach taking over its own healthcare? So I mentioned earlier that the services were traditionally provided by Indian Health Service, which is a federal entity. One of the things that I think is important to know about, not only in Alaska, but also working with many indigenous peoples, is oftentimes the relationship with the federal government historically has not been a positive one. And in general, many Alaska Native American Indian people feel that kind of education and other changes were kind of forced upon them. So like many American Indian people, Alaska Native people, kids were forced to go to boarding school away from their family, and there were unfortunate things like punishments for speaking your language, and also unfortunate stories of pretty rampant sexual abuse within some of the boarding schools, but also by some of the missionaries that came into Alaska. So when SCF took over provision of their own health care, they really wanted to start at the community level and to find out what did the community want in terms of the provision of their health care. And they spent a lot of time actually talking to the community, whether it's through different advisory committees, elder councils, going to gatherings, a lot of personal interactions with customer owners. They looked at satisfaction surveys, employee satisfaction surveys, another thing that you should know about SCF is that over half of our employees are also Alaska Native or American Indian. So they asked their employees kind of what they thought about it. And this is kind of in a nutshell what people said. They thought that the care was often very long waits, that staff were pretty unfriendly. There was not customer input. Treatment was inconsistent. I actually received care at this facility, which actually was condemned after the 1964 earthquake, but it actually remained standing for a while. But this is a picture of, you can kind of see it's kind of sterile looking. When I was a kid and I would go there to get care, the entry to any point in the system was the emergency room. So you went to the emergency room no matter what was wrong with you. And I remember spending, 4 to 6 hours waiting to be seen. You never saw the same doctor, because it's an emergency room. And they did have a primary care clinic, but I think it had like 2 providers. So as soon as my family had private insurance, honestly, we left that system and went elsewhere, and I have kind of since returned. And SCF really has changed pretty much everything from the ground up. So that's on the left is a picture of the old hospital, which has now been ripped down. And then the picture on the right is the Alaska Native Medical Center campus. I think the new hospital was built, I want to say, in 94. So that's kind of the biggest structure. But then a lot of the other structures are really the expansion of the primary care system. So we are now, I think, on primary care building number 3. So, we keep growing and expanding. And part of what they wanted to do was to really set forth kind of what are the principles that we want to use as we move forward, creating this healthcare system. And you'll notice a couple of things about the vision and mission. One is an emphasis on wellness, so really wanting to get away from a focus on pathology, but also multidimensional wellness, so physical, mental, emotional, and spiritual. And then the mission, you see words like working together, so instead of the healthcare system kind of doing to people, that it's kind of a collaborative, shared responsibility type of relationship, and working with the Native community. Our goals are really kind of fall into a couple of different ones, and one is the shared responsibility. So this involves providers and customer owners working together, wanting to provide the highest quality services. Once again, I told you kind of the reputation of the Indian Health Service facility was not a really positive one. One of the things I do want to say is I hope that none of this comes across as being overly critical of the Indian Health Service. One of the things about the Indian Health Service, for those of you who don't know, is that system has been underfunded since its inception, and actually the amount per capita that's allocated to the Indian Health Service and then to different tribes is actually less per capita than an individual in a federal prison. So these are very under-resourced systems, really plagued by a lot of different issues, and there were many great providers within the Indian Health Service, but really it was a federal bureaucracy, lots of turnover, those kinds of things. But anyway, one of the things SCF really wants to do is not to just provide care, but to provide quality, the best care. An emphasis on family wellness. So we think not only just about the individual person in front of us, but what is their family, what's their community health. You heard me talk about customer ownership, and this relates to our operational principles. And whenever we implement something new, we look at these operational principles, and we love acronyms, so there's a bunch of acronyms at SCF, but I'll just call out kind of the key ones. Relationships are really emphasized. So one of the things that is kind of the hub of the system is the primary care system, and each customer owner is impaneled to one primary care provider. It's actually an integrated care team, and so over time, people can develop relationships with that provider and with their primary care team, and this is viewed as really essential in health because how else do you really get to know what people's health looks like over time unless you have a relationship with that person. So really emphasizing that relationship. An emphasis on wellness, locations that are convenient for customer owners. So that's part of why we did the behavioral health integration, but in addition to other reasons, but really wanting to, instead of having a customer owner running everywhere, how can we make this really convenient and emphasize good customer service? Optimizing access. I've mentioned kind of the whole system design. And really, the interests of the customer owner really do honestly, they trump everything else when we are considering new things. So, providers have an important voice, but if it's something providers want to do, but it's not in line with what the customer owner population wants, then SCF time and time again will go with what the customer owner wants. And then to really build on the strengths of Alaska Native cultures. So integrated care teams. So this is the hub of our current system. This has continued to grow and evolve. So I think SCF started off with, 3 or 4 primary care providers, and now we have, 36 as of last count. They are integrated care teams, so it's not just the primary care provider. Each primary care provider has a full-time RN case manager. They have a certified medical assistant who takes all the vitals and helps with some of the triage. They also have a full-time administrative support to kind of help with scheduling. There's a behavioral health consultant that is shared between a couple of teams, although we have more and more now. I think we have 30 behavioral health consultants now. More recent iterations, we've now integrated psychiatrists within primary care to provide med consultation with the psychiatric medications. Women's health has been integrated. Pharmacists have been integrated. So this kind of constantly changes and evolves. But this really is kind of the hub of our system. So if you look at kind of a traditional workflow, it's often very provider-centric, and this is how the many healthcare systems are built. Is whether you need help with a chronic disease or a medication refill, or you want your test results, if you want to do any kind of prevention, oftentimes that kind of all funnels through a single provider, who then may refer you to one of several more specialized type positions. And what SCF has done over time is really to be much more intentional about who can provide what service in lieu of or in partnership with the primary care provider, and really to make sure that primary care providers are providing their unique skill set. So I mentioned all of these different roles kind of down at the bottom. So if you just need a medication refill, primary care provider doesn't need to be involved in that, and I can actually email or text or call my case manager and get my medication refill. There's dietitians who can meet with customer owners, and these are all positions that are integrated within the primary care system. And I think you saw the picture with the desks. Literally, people sit right next to each other. So there's not an individual office for the primary care provider, but people literally sit right next to each other so that they have ready access to their team. part of kind of keeping track of, are we providing the best care to our customer owners? SCF has a really robust quality improvement, quality assurance system, and so this is an example of a scorecard from FY15, and it's just select metrics. So we do measure customer owner satisfaction. So our rates are usually, in the mid-90s. We do look at operational effectiveness, and so you'll see some of the screening rates. We track cervical cancer screening, colorectal cancer screening. Some of the stuff I'm going to be talking about today is our depression screening, and ESPERT is our alcohol screening, and they look at kind of subpopulations. So these are rates of diabetics who with A1C levels in poor control, and then diabetics with LDL that's in control, and then the overall screening rates. You'll see overall the items in the green are where we want to be, and items in red, we're not where we want to be. Colorectal cancer screening is one of those areas, and that partly relates to kind of the backlog that happens in trying to get people in for colonoscopies. So we continue to work on that rate. We also look at workforce development, and so you'll see once again more than half of our employees are customer owners, and we have goals around So I'm going to now move into more of the research. Let me see how I'm doing on time. So research. SCF established their own research department in roughly 2004, and I became director, has it been 10 years? I guess in 2005. And we have been asked to work within the corporation. And so we're integrated within the corporation. We actually are members of all of the different clinical team meetings that happen kind of at a bigger picture level. And we've been asked to directly respond to the health interests and the priorities of the population. And the way that these are kind of captured are what we call our family wellness objectives. And I know this is kind of primarily an audience of maybe people going into preventive medicine, but the way that those priorities were really chosen was not only what stakeholders were bringing up, but really looking at what are the major contributors to morbidity and mortality in the Alaska Native population. And so we have 12 of them. They run from cardiovascular disease and cancer. There's 3 or 4 behavioral health priorities, so suicide, substance abuse. We have a lot of oral health disparities, obesity. So, as the Alaska Native population kind of becomes more westernized through diet and other factors, we've seen more kind of the chronic diseases kind of starting to become more prevalent. Right now, diabetes is actually lower than the general U.S. population, but based on kind of what we know about the changing diet as well as things like metabolic syndrome, we expect that to be changing. So we try to pick research projects that are in line with these priorities. So it's a very different model than kind of a researcher who's done kind of one type of research their whole life, kind of coming in and saying, hey, I want to do this study. So I know my portfolio is very broad. We do a lot of partnering with specialists in different areas. And it's really to respond to kind of this guidance that we've been given. And we do have a lot of guidance from customer owners. All the research that we do goes all the way up to the executive committee and the board of directors, and they give us input and ultimately approval. And then there's the very pragmatic funding opportunities. So sometimes what we want to research doesn't really fit with what NIH wants to fund, and so it's kind of a combination of these different factors. So now I'm going to jump into more of the research components, and I'm not going to go into any of these in any kind of depth. And I have my email at the end of the presentation if any of you want any more information about these publications. I'm happy to send them to you. So some of the early work that we did was really looking at this transformation in primary care, and did it really make a difference? And so this publication describes a series of a set of time series analyses that we did looking at different factors kind of before, right around the time of the transformation in 99, 2000, and then kind of what happened afterwards. And most of the graphs pretty much look like this. So this is the percent of customer owners with one or more hospitalizations per month for any reason. And once again, the transformation really took place in 99 to 2000, and so you'll see kind of this drop in hospitalizations. We also did find drops in things like unintentional injuries, which honestly we weren't expecting, asthma, and pretty much many of our metrics have kind of stabilized since then. So that was kind of some of our early research that we were asked to respond to. One of my areas of interest is, as a psychologist, it has been in behavioral health. And I provided direct clinical care in the specialty behavioral health clinic when I first started working for Southcentral Foundation. And one of the things that became very clear to me in talking with primary care providers is that most people weren't making it to the behavioral health specialty clinic. There was a lot of stigma associated. Some people didn't even want to be seen in the waiting room of the behavioral health clinic. But SCF has always been very aware, and this partly comes from our CEO, president. She believes behavioral health is in many ways kind of drives many of the more medical health disparities that we see. And so she's always been a huge advocate of behavioral health services, which is, of course, something that really got me to return back home. But one of the things SCF did, and this was even before the time that they integrated behavioral health consultants into primary care, they might have had like one behavioral health consultant, but back in 2001, kind of with this recognition that there's these unaddressed, potentially behavioral health issues, is they started an initiative and they worked with the Institute for Healthcare Improvement to initiate a clinic, population-wide screening for depression in primary care. And so this is called the Southcentral Foundation Depression Collaborative. For those of you who don't know a lot on depression, and I spoke about major depression here, but really even subclinical depression can have a very dramatic impact on health, and it's very common. And American Indian, Alaska Native people, even more than the general population, is going to go to primary care or to general medical providers kind of for underlying behavioral health conditions and not go to specialty behavioral health clinics. So kind of with that background, they began screening all adults using the patient health questionnaire. So this is a questionnaire that's really set up for primary care. They always want to make sure that their screenings are brief. Plus, the primary care providers, if they actually did all their screenings, it would take a long time. So brevity is always really important. And it looks at the presence and frequency of 9 diagnostic criteria within the past 2 weeks. Then, depending on the score, there's different levels of intervention that were recommended. And I don't know if you guys can read this, but basically it starts at the top. The first 2 questions of the patient health questionnaire are asked, and then depending on responses for that, they may be given the rest of the instrument. And then depending on whether it's mild, moderate, or severe depression is going to kind of warrant next steps. So for some people, especially if there's some suicidal ideation or a plan, obviously those folks were immediately referred to the behavioral health clinic. They're now seen by behavioral health consultants. And a big piece of the Depression Collaborative was really about antidepressant prescriptions. A lot of those were being done in the behavioral health specialty clinic, which really kind of backlogged everything with psychiatry. And there's, really, there was a recognition that primary care providers could play a role in antidepressant prescriptions and monitoring that over time. So the goal is to, if customer owners are open to it, to get them started on antidepressants and then to kind of follow them over a 10 to 12 week period of time through phone calls from the case manager and really looking at whether the PHQ scores are going down. So one of the things when SCF first got ready to implement this, the primary care providers were honestly scared. They were really worried that this was going to backlog everything in their clinic, that everybody was going to be positive for depression, and that's all they would do. This is what really happened is 82.8% of the 14,000 people screened were negative for depression. And that leaves about 17% that had mild, moderate, or severe depression. We found that to be remarkably consistent in the different studies that we've done. It's always been about 17%. What was interesting about the people that screened positive is that less than half of them had been seen in behavioral health in the year before. So we really were potentially picking up new cases. And then of the people screening positive, more than half agreed to take an antidepressant, and then 70% either had follow-up visits of some sort or antidepressants. So what this kind of showed SCF is really that you could implement a depression screening and management protocol in primary care without shutting the clinic down, and that there were indices that this was maybe picking up on people who previously had been. But one of the things was that not all eligible individuals were being screened, and so this was kind of one of the first set of questions that I really wanted to understand. And my sense is that there was probably systematic variation on patient and provider levels about who was getting screened and who wasn't getting screened for depression. And so I started this work, I think it was in 2003, and it was my first project. It took a while. I think Dr. Manson's here. It took a while to get approval for my project when I was transitioning back into research. But this is kind of one of the first studies that I really led. So what we wanted to understand was what factors are associated with depression screening coverage. Obviously, if people aren't screened, then there's no chance that any depression or other behavioral health distress they may be having could be intervened with. And so we queried data from the electronic medical record over a little bit longer than a year period. We chose that because everybody's supposed to be screened once a year, and we gave them kind of a couple extra months on the other end because it was a newer initiative. And then we did multi-level logistic regression to look at what was associated with receipt of screening, and we did have to take into account the nesting. So I mentioned that each primary care provider has kind of a set of customer owners, and so we did have to take that into account when we did our analyses. And so what we found was that the overall screening rate was 47%. Honestly, with how busy the primary care providers are, I actually thought that this was a pretty impressive rate. And interestingly, the rate has remained fairly steady, between 40 to 60%. There's a large proportion of customer owners who may come in like once or less a year, and obviously if somebody's coming in with a cold or the flu, things like depression screening might be being missed. And there's other factors, as we'll kind of see. So the intra-class correlation really looks at how much of the variation in screening rates could be attributed to who the provider is and what team they're within. So primary care providers are also within a team. And it looks like between 8 to 10% of variation is really kind of at the provider team level. So these next series are a series of graphs looking at kind of what we found. So what we found is that whether you are male or female, as a customer owner, you're less likely to be screened. And those are individuals that are 18 to 34 years of age. Part of what is kind of interesting about that is if you think about things like suicide, which definitely are not fully attributed to depression, but rates of suicide are highest among Alaska Native men, like 18 to 26. And so, particularly the screening rate of 37% among males was definitely not ideal. The more chronic conditions people had, the more likely they were to get screened. we weren't really sure kind of which direction this would go, because if you have a lot of chronic conditions, maybe, depression falls to the bottom of the list to really, but I think there's a, recognition a recognition that many times these are comorbid with a behavioral health issue. And providers are actually prompted, one of the things I forgot to mention, providers are prompted for this. So in their PCC plus form that prints out whenever a customer or donor comes in for care, it actually has on the top left corner in lists of overdue screening. So this could be pap smears, it could be colorectal cancer screening, whether they're due for their depression or alcohol screening, all those things. So this is even with those type of supports available. Service utilization, so obviously the more likely you came into Alaska Native Medical Center, so that's both the inpatient and the outpatient, more likely you were to be screened. We thought that perhaps whether you had depression diagnosis in the past might differentially impact whether you were screened for depression. This was only significant in females. So if women were previously diagnosed with depression, then they were more likely to get screened. Substance abuse was not significant, nor antidepressant dispensation in the year before, so I don't have graphs for those. We also looked at provider factors, so we got these factors in working with our human resources department. And actually, none of these were really significant, except for, but you see kind of this slight bump in 2 to 5 years of tenure with the organization, and then kind of a, depending on whether you're male or female, kind of a leveling out after that. There was also this interaction between provider gender and then customer owner gender. So this was only significant in males, and males who had a female primary care provider were less likely to get screened than males with male providers. And these were all multivariate analyses, so these were simultaneously accounting for all the other factors. What we still found is that even when we were doing the nesting, that there was still kind of this unexplained significant effect for providers. So, provider variation definitely is a factor. And so what we learned was really that in this kind of clinic population-wide screening initiative is that even though the infrastructure was set up so that everybody would get screened once a year, is that there were these very systematic variations in who actually got screened. And I've kind of called attention to the population that really seems to be getting missed. So the next effort that I wanted to look at was really, so there's, people who get screened, but if you get screened and that's it, that's really kind of an incomplete addressing of depression. And so we wanted to also look at whether people were, where there was some sort of indication in their medical record that their provider or somebody noticed that they screened positive for depression, whether it was a behavioral health diagnosis. We also looked at the progress notes to kind of see if there was anything about depression in the progress notes. Part of why, as we heard from our providers, is that they were pretty reticent to diagnose people with depression. These are not behavioral health specialists, but, also understanding that there can be kind of some stigma associated with that. So we looked at the actual progress notes. And then we looked at, again, through manual chart audits, whether the proportion who had guideline concordant management, and this was in the first 12 weeks after positive screening, and to look at whether that management varied according to patient and provider factors. And so we did a manual chart audit among 400 customer owners who had screened positive, and these were people who were newly screening positive, so these weren't people who had screened positive before. And we did this manual chart audit and then, again, did multi-level logistic regression. And what we found is that about 35% of people who screened positive had a depression diagnosis noted in their chart. And then another 38% had depression symptoms noted. So for the most part, providers were noticing the screening and doing kind of an assessment to kind of try to figure out what was going on. And detection was higher among patients with moderate and severe depression. In the roughly 100 charts where there was not either something about depression in the note or in the diagnosis, we actually found that about half of them had another behavioral health disorder either diagnosed or kind of considered, most often anxiety or a alcohol or drug abuse disorder. And then also chronic pain was mentioned quite a bit. And I know chronic pain is often comorbid with behavioral health. So, once again, it looked like we were kind of the logistic regressions, really a lot of things were not significant. What we did find is compared to the screening is that the younger customer owners who were screening positive for depression were more likely to get management according to kind of the guidelines versus older adults, which is interesting. And we also found that management varied according to experience within the clinics, and most notably providers who had been with SCF for 5 or more years. So to give you an example, for providers who had 5 or more years experience in the clinic, 73% of those customer owners received guideline concordant care versus 55% of patients with providers with less than 2 years of tenure. Other things that we looked at, like provider gender, number of chronic conditions, service utilization, all of those weren't significant. So once again, I think what we learned from this is that really most of the people who screened positive, this was being picked up by their primary care providers, and it does look like, at least for the majority of them, there were some attempts to kind of initiate treatment with, once again, some of these variations in patient and provider factors. So I'm going to really go through much of this much more quickly. So we also had a study where we looked at screening and brief intervention referral to treatment for alcohol misuse disorders. And these are results from that effort. So we screened 14,000 individuals. Notably, 45% screened negative, 17.5% screened positive. And then once again, the level of intervention provided really depended on the level of the score. And I don't have a lot of slides to present about this one, but basically what we found in this effort is that sometimes quantity and frequency of alcohol use were not always correlated. And so as with other American Indian or other indigenous people, there may be this kind of episodic drinking that might be important for us to kind of pay attention to moving forward as a system. We also had, within the protocol for management, we had a follow-up with a referral to a sister agency, and we lost quite a few people, although, overall the initiative was a success. And part of what this funding really allowed us to do was to expand the number of behavioral health consultants. SCF is always changing and growing, and for the most part, when SCF starts talking about some new initiative, most of the time primary care providers they're not always enthusiastic, but they have loved the behavioral health consultants. And so as I mentioned, we went from, I think, 2 or 3, and now we have 30 behavioral health consultants, and they've become more and more integrated, and this has been widely embraced not only by providers, but also customer owners. Customer owners view behavioral health consultants as just a member of kind of their team. So some other efforts that we have done is we've developed a depression management support tool. Part of what we're trying to do is to figure out how to best engage people with depression into their care. And, at first the initiative was really heavily focused on medication because it was within a primary care clinic without a lot of behavioral health consultants integrated. Now there's a lot more brief intervention that's being offered. But we also wanted to engage more with customer owners to find out kind of what are they interested in. Part of what we were thinking was happening is that, and probably some of you do this with your doctors, unless you're like me where I ask a bunch of questions, but a lot of times, you go to the doctor and they tell you to take this medication. You may say, okay, I'll take that, but then, people really demonstrate with their behavior kind of whether they're going to, take the medication, which could go back to kind of underlying beliefs and values of kind of what types of treatment they want to do. And so we developed this depression management support tool, and we have just some of the results that are in, but we really looked at stakeholder priorities and developed and pre-tested this decision support tool. So what we've heard from our customer owners is even after this behavioral health integration for over a decade now, is there still, remaining stigma around depression and behavioral health issues. And so they really wanted, part of what they wanted to know was that they, that they're not crazy, that, depression and other behavioral health issues are common, and to provide information about, how often does it occur, what contributes to it, and then to talk about different treatment options. And this is a picture of kind of the, it was actually an iPad-based app. One of the key decisions that we made moving into this, into developing this decision support tool, is we really wanted to prioritize what customer owners may want to take advantage of, regardless of whether there is a lot of Western scientific evidence. And we made that decision for many different reasons, but one of which is, there's not a lot of research about depression in Alaska Native and American Indian people. And I know at the time I did my first study, I think there were 3 studies about depression, about behavioral health in primary care in Alaska Native American Indian people across the whole nation. So it's not an area that we know a lot about, but you'll see that we included spirituality, we included exercise, eating, traditional healing. We have a traditional healing clinic, and we also know many of our customer owners are more interested in herbal remedies than medicine. You'll also see kind of down at the bottom, there is a place for somebody to indicate that they're not really interested in treatment, and that's a sign to the primary care provider. This isn't really something that they really want to address kind of at this time. And we have since also developed a website that goes over information about depression. Another thing we heard from our customer owners is that they wanted to make this decision not necessarily on the very same day in clinic, but also wanted to talk to their family members and maybe other important people in their life about what to do. So we have since evaluated this decision support tool, so we randomized at the clinic level, and we had 375 people present. The tool actually was very brief. The median was 4 minutes, and that was actually 2 minutes longer if a behavioral health consultant, we kind of allowed flexibility in how the tool was used. So some people wanted to look at the decision support tool by themselves without a behavioral health consultant. Some people wanted the behavioral health consultant, so we allowed that to kind of vary. But it's definitely something that could be implemented in primary care. These are, part of what's interesting is that even though we spent all this time adding in all of these other non-traditional, quote, non-Western interventions, is really what people are most interested in learning about was counseling, medications, and then kind of down at the bottom is kind of peer support groups. These are the preliminary outcomes. We basically found no real difference between the intervention and control clinics in many of our measures. One of the things is our control clinics, they provided care as usual, which does involve depression screening as well as referral to a behavioral health consultant. So we were really just trying to kind of test whether the decision support tool added anything. Interestingly, though, what the decision support tool does appear to have done was to decrease frequency of primary care visits. And we're still kind of in the process of analyzing this and kind of thinking about what that means. But we also didn't really find any changes in the post period. I think it was 6 months. There were no differences between the clinics. So an example of kind of where we implemented something thinking it was potentially going to make a big difference. Overall, customer owners really liked it. The providers liked it. We're in the process of kind of discussing whether we're going to go ahead and implement the tool. So I think at this point I'll stop. I have a lot of other studies. More current efforts that we're working on is we are screening for, we're piloting a screening for trauma in primary care. So this is people who may be having nightmares or flashbacks related to maybe domestic violence or child sexual abuse, those kinds of things. Very collaborative process to come up with the screening and intervention protocols. SCF is also more and more trying to figure out how can they do targeted screening with populations that are most at risk rather than kind of population-wide screenings within primary care. And so I know that right now kind of one of their new initiatives is really looking at people who use the system a lot. So these are people with 20 plus visits to the primary care system within a year. And so what is the system kind of missing, and really trying to directly engage with those customer owners and see what's missing and how can we better support them as a system. So this is my email. Feel free to contact me with more information. And if it's about parts of the system that I don't know a lot about, since I've worked there for so long, 16 years, I kind of know who to kind of reach out to. So at this point, are there any questions or comments? Thanks. Yes.
Hi, thanks so much. This is fantastic, and it's very inspiring actually to hear about all these interventions that have been done in a place where there's not enough funding and there's so many barriers already. So thank you. I worked as a primary care provider at a reservation, Fort Defiance, Arizona, and we had a somewhat integrated system, not as integrated as this. Our major issue was lack of behavioral health consultants and lack of resources. We had a major amount of turnover for psychiatrists and therapists, and we just didn't have people in our psychology and psychiatry department. So clearly, that would have been a major improvement if we could have expanded upon our behavioral health section. One thing that I'm wondering about is naltrexone for alcohol abuse. So as a primary care provider, I could provide antidepressants. I didn't have a lot of time to provide therapy. We didn't have a lot of behavioral health consultants. What I could have done, though, was to treat alcohol abuse more effectively. And more, especially in populations that deal on a very large scale with alcohol abuse, naltrexone is being used. Do you have any experience with that, or have you looked at models putting sort of alcohol abuse treatment, medical alcohol abuse treatment, into the primary care model?
Yes, so there's been changes in that too. So behavioral health used to have a specialty in naltrexone clinic, and so they would run groups and have people come in. Part of the requirements of being on naltrexone was that you had to be in some sort of other intervention, whether it's AA or a formal inpatient or outpatient program. We've actually, more recently, they actually have moved naltrexone prescriptions into primary care with the assistance of psychiatrists. It's very new, so I'm not sure kind of what it's going to look like. I do know, I think that this was a very big mind shift for the psychiatrists to think about primary care providers prescribing naltrexone. But, once again, we're always trying to figure out as a system how can we most effectively use psychiatrists or very specialized folks. One of the things I would also mention about behavioral health integration is it's a very specific type of behavioral health provider who's going to work in these integrated systems because, and I have this Western training myself, Western training often is very much kind of long-term therapy. You're kind of individualizing kind of a treatment plan kind of by yourself, and behavioral health integration is completely different. So most of the services that the behavioral health consultants provide are 10 to 15-minute interventions, and they're very focused on kind of immediate needs, more focused on kind of strength and resiliency and how to kind of maximize those. We have found that you can't just take somebody from the behavioral health specialty clinic and put them in primary care and have it work very well. So we actually recruit very critically for that, and I think we have found the same thing with psychiatrists. So, yes.
Thank you, Denise, very much. One of the things, I don't know if you mentioned or not, but it was implied in the move from 2 to 3 behavioral health consultants to now 30, is that the data that went along with these initiatives as they were developed and launched was sufficient to convince the state of Alaska to revise its CPT code so that Medicaid now provides for a good chunk of the support for these behavioral health consultants, which just underscores the importance of doing this kind of rigorous evaluation at the same time and the ultimate sustainability of these kinds of services. So, great work.
I had a question about the creation and implementation in regards to IHS, like how you guys were able to get through both systems.
So we actually receive, the way compacting works is you actually receive, it depends on if you take over a provision of the whole system or parts of the system. But actually, we really just get the money from Indian Health Service. So the money goes from Congress to the Indian Health Service and then directly to Southcentral Foundation. So we're actually, parts of the hospital are still Indian Health Service, or we may have Indian Health Service employees. But really, for the most part, there's not very many Indian Health Service employees anymore on the campus.
Did they try to impose any direction for you, or did you guys have to get approval, or that kind of?
No, it's actually part of this law that I mentioned was really giving tribes the enabling them to use their sovereignty to take over provision of their own care. So tribes are sovereign nations by treaties, and so part of this law was that tribes can take over their own health care and they can take over their own education services. And many tribes have exercised that sovereignty, but some have not. Alaska, I think, was among the first to really do that, and they've had a lot of success. I don't even know if there's any Indian Health Service run facilities in Alaska anymore. I don't think there are any, which is very different than other parts of the country.
I know that Native Americans have some of the highest suicide rates in the country. You know, it seemed to me that your organization, being more responsive to the local culture, would have an impact on that.
Yes, and actually suicide rates in Anchorage are actually lower than much of the rest of the state, but they're still like twofold non-native people. So SCF, so we do have behavioral health specialty care where we're trying to, impact people who may have recurrent suicidal behavior. There's different initiatives to really kind of expand awareness in the community of kind of warning signs of suicide, and at least to get people to start talking about it. That's been one of the barriers, is people are kind of reticent to talk about suicide. But things like alcohol misuse are, often co-occur. So it is an area that we are trying to pay attention to, but, honestly, it's an area where there's still just way too many deaths, and in more rural areas they may have cluster suicides sometimes, and so that's one of those areas where what is effective and what will make a difference. There's different groups in Alaska working on that. I know Center for Alaska Native Health Research, they work out in the western part of Alaska, and they found some success with an intervention that was built kind of from the ground up and really, in some ways, manualizes kind of cultural lessons. And it's working with youth. So it's an example of an activity, maybe going fishing with an elder. But it's not just about the fishing. It's about building that relationship with that person. It's about all the lessons about how you respect, the land and the fish that provide for you. And so, so there's different efforts, but this is an issue across the circumpolar north. I know that I'm involved in, it's called the Rising Sun Initiative, and it's really looking at the high rates of suicide kind of across the circumpolar north. Whether the darkness has a factor, that's kind of the question that everybody's trying to figure out. So, yeah.
That was was a wonderful presentation. Thanks so much. I know you weren't able to show all your data on the first study with the PHQ-9 screening. I'm wondering if you found any correlation between those that were employed versus those that weren't, and if you have a connection to some of the major employers for these groups in terms of supplementing this sort of intervention.
Yeah, that's a really good point. One of the big limitations of that particular analysis, as well as some of the other information that we look at, is in general we don't have good psychosocial indicators. I think we've moved to Cerner recently, and I think at least now the data is not being overwritten. So for a while, in RPMS data was being overwritten, so we really had no sense. I think that those are really critical, and that is a big limitation of the work that we've done thus far. Is we can look at zip code and kind of a proxy for income, but it's not real income. People don't actually want to tell us their income. Is what we found when we're looking at eligibility for services. What we found that has worked best is either you're above this amount or below this amount, and that kind of seems to be what people are comfortable in offering. And once again, in a system where it's all about customer owners, but we've done some work looking at zip codes, but things like education, employment, those kinds of things in general, I would say that we don't have ready access to that information. I know at least within behavioral health, those types of factors are very in-depthly explored, but that is a big gap in our system, especially because we know that many health disparities can be really driven by economic and other inequalities. So it's definitely a good question. Yes?
You mentioned that you also look at trauma, and I was curious how you screen for that. Is it adverse childhood experiences, something else? And then how is that incorporated into the care?
Sure. So we decided not to go the ACEs route. And the reason why we decided to not go the ACEs route is for a couple of reasons. One is really has to do with, is it really that important what happened in people's early lives, or is it important whether those events are still impacting them now? And so we made a decision to focus on whether they were impacting them now and looking at symptoms of PTSD. So we used the PC-PTSD score. We also, and I know for a behavioral health trained person, I know for me, I think that sometimes we don't realize how some of the questions, the way that they're worded in behavioral health, how disconcerting, if not offensive, they can be to people when you just randomly hand them the screener, and you ask them, have you, been sexually abused? And so I know that our corporation has been really wants to be really sensitive about how questions are asked and that they're not re-traumatizing to people unnecessarily, and also that, and particularly asking people questions like the ACEs questionnaire and then not having any services available. So we actually have we haven't used the ACEs approach, but more of a symptom-based focus with screening actually done by a behavioral health consultant who's then able to offer the brief intervention right then and or referral. We also did develop a brochure that kind of goes over what trauma is, kind of the common impacts, what might help, and we actually made a decision whether people screened positive or negative for PTSD symptoms to actually go over the brochure with everybody. Because, the thought is that even if I'm not personally exposed or experiencing trauma, probably someone in my family and definitely someone in my community is. And so really wanting to kind of get the word out, that this may be a really important factor to look at. And I know, we're waiting for the results of this pilot, but I know that the behavioral health consultants are also talking about maybe making the trauma screener kind of one of the primary screeners that they do, because it's also picking up other issues. But that's kind of how we approached it. And I think I missed this whole half of the room. Any questions or comments over here?
I think we should actually wrap up.
Okay.
Can I have a hand?
Thank you all.